Hello, everyone. Thank you for being here today. It's been a week of continuous health updates, and I'm sure that many of you would have tuned into the public briefings. I'm Samiksha. I will be the moderator today. Joining us this crisp, cold morning are Lesa Semmler, Minister of Health and Social Services, Alan Doody, Deputy Minister, Health and Social Services, Dan Florizon, Public Administrator, and Terence Coutray, Assistant Deputy Manager, Health System Sustainability Unit from Department of Executive and Indigenous Affairs. We'll start the media briefing with some opening remarks by Minister Semmler. Mr. Semmler, if you may, please.
Thank you. Good morning. Sorry I can't be there in person, but I'm sure you don't want me to. You don't want to catch what I got. So thank you for joining us. As we close another year, I want to share some of the progress that we've made to strengthen the health and social services in the North and to advance our vision of healthy people and communities. When I accepted this role, I knew meaningful change required a clear understanding of what works, what doesn't, and what improvements are most needed. It also requires an alignment with available resources. Over the past 2 years, we've listened to staff, Indigenous leaders, patients, and families. They spoke about fragmented care in small communities and the stress of medical travel, racism some Indigenous residents face when accessing care. That feedback has helped shape 3 key priorities for our health system, which are to modernize medical travel, so it supports care rather than adding stress for patients and families, strengthen care in small communities by providing greater support for community health nurses and developing a model that ensures continuity of care as close to home as possible, embed cultural safety and anti-racism throughout the system to ensure every resident receives equitable, respectful care. These priorities reflect what matters most to Northerners and align with this government's mandate. As Minister, I've directed the Department of Health and Social Services in collaboration with the Northwest Territories Health and Social Services Authority to take action on the following priority areas. Simplify medical travel by updating the policy so it's easier to understand and navigate, ensuring residents can access care they need. Advance primary health care reform by developing an Indigenous-centered model and co-design workshops. Promote cultural safety and anti-racism by delivering training across the government of Northwest Territories and co-developing accountability tools with Indigenous governments. Improve access and continuity of care throughout the work of on our small community model of care project, which will better serve residents in remote communities. Beyond these initiatives, efforts are also underway to tackle long-standing pressures in the system. Costs are rising faster than resources, compounded by climate change and inflation. That is why sustainable delivery of health and social services is a priority for this government and the 20th Legislative Assembly. Throughout the healthcare system sustainability unit, work is underway to analyze which service should be core to the Northwest Territories and how they can be delivered efficiently while protecting access to essential care. This work is collaborative, involving the Department of Health and Social Services and all 3 health and social services authorities, ensuring decisions reflect operational realities and community voices. Progress is happening across the system. We have seen reduced reliance on agency nurses, expanded supports for residents recovering from addictions, increased resources for remote health cabin communities, and progress working with our federal counterparts and successfully securing federal funds for addiction medicine, detox, cultural safety, and medical travel. These are just a few examples of the work underway to strengthen access and improve coordination. Challenges remain, including staffing shortages and burnout, but across the system, there is a true commitment to find solutions to build and support representative workforce. Our responsibility as leaders go beyond accountability. We must champion our communities, create conditions that attract and retain talent, and celebrate improvements as they emerge. Together, we can build a system that reflects the lived realities of Northerners and achieve our shared goals of healthy people and communities. Thank you.
Thank you so much, Minister. Now I will open the floor to media. we will go alphabetically. They're just two, with each reporter getting one question, one follow-up. And once both the reporters are done, we'll open the floor to any extra questions. If you have any specific question to the panel, please mention who the question is directed towards. So we will start with Lisa from Go FM.
Thank you. So this question is for Minister. Oh, thank you. This question is for Minister Semmler. Thank you again for inviting the media today. I appreciate the chance to hear more and to speak with you. And I know that there's an overhaul being planned of the healthcare system following the budget talks, and I wanted to hear a bit more about that.
Minister?
Yeah, sorry. So when we're looking at the healthcare system as a whole, I think when I started as the minister, the piece that we started to focus in on are what we've been hearing from residents. And I think when we create our mandate as and our shared priorities as all MLAs, access to care was the biggest piece. And it's right from the small communities to our capital, where every single MLA has brought forward access to care issues. So where we started, where I began to meet and travel throughout the territory and hear from residents. We also did town halls with every region and within the health authority with the staff. And so we took all of that feedback, and where we are starting to focus on are the three biggest themes that we've heard. So within the medical travel, we do spend large amount of money to move people around, and sometimes, as many people have heard, is sometimes they'll travel for a 5-minute appointment, and then they travel vast distances. But sometimes I've heard it right from Block to all the way to Edmonton for a 5-minute follow-up appointment and then go back. So what we're doing in the system is we're taking a look at how we're moving people, and so that we can also make sure that when people are traveling, they're traveling because they need to have that in-person meeting. And we're looking at other ways to save costs, but also it's not just saving costs, it's the burden of people that have to travel. They don't want to travel. So in the same space, we're looking at that piece. The other area is the model of small communities. In our smallest communities, we lack a lot of services, and so that way many people have to travel to the capital. As you know, you live in Yellowknife. It's very complicated sometimes when you hear the concerns of people trying to access care. They're trying to get into the primary care clinics and trying to get into the emergency. Our system is overloaded at capital because we need to do some work in our smallest communities to get them services. So it'll take the pressure off of our capital. And so when we look at moving forward, and I think this is a piece that incorporates the healthcare sustainability unit, is we have to be looking at what we are providing as core services and how are we funding those, and are we spending a lot of money in areas that are not dealing with these big ticket items, and so that we can refocus the efforts into the area that needs the most to people, and the financial pieces can be targeted to those areas as well. So why you see 3 different people in the room with me is because I have a deputy minister. We brought on the public administrator. Then they were working together. We brought on the healthcare sustainability under the premier. And now we have to have them all working together for that one goal, because we need to ensure that we're providing access to care to our residents in the Northwest Territories in a sustainable way. As you see, year after year, we've been having deficits, and we need to make sure we're right funded for the things that are important to the Northwest Territories residents.
Thank you. And I wanted to also ask, I know there's a lot of, when it comes, for example, to like mental health and addictions, is there anything that's happening within the next year, like in the recent is in the near future to help people who, so that they don't have to leave their communities, that they can get help and resources within their communities if they're living sort of in more remote regions and smaller communities?
Thank you for that question. So one of the pieces that we have done is we've heard from many of the Indigenous governments that want to be in that space in their small communities. And so what we do is we have the Mental Health and Addictions and Recovery Fund that we have for Indigenous governments and Indigenous groups to apply on so that they can provide care in that space closer to home. We've also, we as the Northwest, like within the NTHSSA and the THO Service Agency and the Hay River Authority, there are mental health and addiction workers within the system. We have many of them in the smaller communities as well. As I travel through the Northwest Territories, in some of the most smallest communities, there are mental health and addiction workers. However, there's this piece about some people want to go away and, they have multiple, polysubstance addictions. And so we're not, in the smallest communities, we're not well equipped to be able to provide that type of service. And so where we're trying to fill that space is we're trying to make sure that we are establishing, when they do come home, pathways for them for aftercare. And so right now we have established the transitional addiction recovery program, one in Yellowknife and soon to be one in Inuvik. And those are for people coming back from treatment so that they land where they have a home for a temporary period of time to transition them into, back into their communities. It's really difficult with our logistics in the smallest communities because a lot of times when people have mental health and addiction issues, there's not, even within that area, we do have vacancies. We still are struggling with recruitment in that area as well.
And I just had one more follow-up, if it's okay.
We can read like all you.
Okay, go ahead. Okay, thank you.
There you go.
Masi. Thank you, Masi. I just wanted to ask, I know a lot of the models are turning to like virtual, like looking to virtual MDs and different professionals, like virtually, like connecting that way. And I'm just wondering, is there a plan to get more connectivity within some of these remote regions, which might help with some of the like with the sort of healthcare models that are more remote? Thank you.
Thank you for that question. I'm going to pass that one. I'm not sure if it's, because I know we have discussed connectivity and implementing into the healthcare. If it's Alan or Dan, who wants to answer that within the healthcare, especially outside of the capital?
Yeah, okay. Thank you, Minister, and thank you for the question. As we're going through with the first region that we've done a deep dive in, which is the Decho, we've identified opportunities, not only use of technology on the ground for point of care testing, which are small units, small pieces of technology that give immediate results, but also to be able to create an expansion to our existing virtual network. So right now we have cameras and televisions. We're expanding to have audioscopes and stethoscopes, and we're looking at other tools that can be used so that the virtual care out of Stanton or Inuvik can be provided into our smallest of communities. So the physician has always been available, those physicians via phone or traveling to them, but now we're offering a broader base. Connectivity has been resolved in part by using what's there, investing in new technologies, so satellite connectivity. We can always use more, but I've got to tell you that there's a capacity right now that the existing connectivity, there's a capacity to expand what we're doing, and we're continuing to expand within that space. So I haven't bumped up against the limits of connectivity in small cabin communities, but it's always a challenge. The other piece is EMR, so the medical record or the health record. We've now made greater availability to health cabins based on what we've witnessed. So while those technologies are being looked at and examined by the Department of Health and Social Services, while those technologies and connectivity are part of the infrastructure discussion of writ large of government, my job in the short term as a public administrator within the NTHSSA is to take advantage of what's already there. And as we see an expansion of virtual care, as we see an expansion in connectivity, we're going to fill that room with the ability to have care provided at home or as close to home as possible. It's really fascinating because part of the burden of what we're feeling in Stanton with the number of patients and the sheer volume that our staff and physicians are encountering, care being provided at home or closer to home in the regions assists in relieving that. So there's travel that can be avoided. There's care that can be provided. And if we can avoid having the crisis that led to hospital admission, if we can do that through our preventative and promotional activities online or virtually, or through itinerant services, that's a win-win-win. And that's the approach that we're taking. We started with the debt show. We're going to move region by region throughout the territory.
And is there a timeline for that? Or?
We have the debt show work is underway today. It has been underway for several months. It will be concluding by March 31st. 80% of the operational action plans have been completed. These plans are not just about virtual care or point of care testing. They're also training and certification of staff. They're looking at infrastructure and equipment needs, other needs within the health cabin communities. So we have a whole range of action plans that we're working. Effective April 1st, we'll be in a position to move to our next region. We're going to cycle through, and we can start to do some concurrent work, but we're learning a great deal from the debt show that has application to every region throughout the territory. We'll be hearing more about this because there's a story to be told here from the teams, the staff, those that are patients and seeking care about the improvements that are possible. So it's a deep dive.
And in the meantime, the other regions, they will be, is there a way to kind of get them just some basic connectivity just without access? Is that in the works?
Yeah, thank you for that.
I can take that one.
Oh, sure. Sorry, Minister.
Yeah. And I think right now we have implemented it, I think we learned during a lot of the disasters that we've had that connectivity has been a huge piece. And we just, like myself and the Deputy Minister, traveled through the Nunavut with Minister Kaptana, as that's her riding, and we met with within those communities they're our most remote, and I believe that there has been some implementation of Starlink into those communities to have backup. As if you drive through those communities, everybody has a Starlink on their house, because that's basically the only connectivity that they do have. That's stable. So we have implemented that kind of as a backup in some of our facilities, and I think we're going to continue to just monitor that. But with that, saying that is Starlink is not, and when we look at the fiber line, would be connecting into the fiber line, and all of our communities that have the ability to is where we want to be, because that I think is going to be, and using these satellites as backup. So however, in our highest Arctic community, those are on islands way up in the coast where the fiber line does run to those, so we will always need a backup and using satellite internet in those communities.
Thank you, Minister. Just to supplement, the learnings that we've had in the health cabin communities in the debt show, the training, the technology, the approach that we're taking has been now shared and spread to every health cabin community in the territory. So we're not waiting. We're inviting in all health cabin communities to be part of the improvements that are occurring. But the DECHO has been the motivation, the center and hub of our learning.
And can you give an example of what one of those learnings might be?
Lisa, can we come back to you again? Yeah, sorry, Wally. Yeah.
Thank you very much, guys. Just quickly on the DECHO front, I wouldn't mind just covering that off a little bit more, the DECHO trial, just in terms of, I know, Dan, you've covered some of the aspects there. Are there any aspects of that trial in the DECHO you didn't just talk about that are important to mention? And after March the 31st, you sort of just said at the end there, we're already rolling out these lessons to other health cabins. Can you talk a little bit more about what is being implemented elsewhere now as a result of that, and also which region will be next?
I can start with that and then
Sure.
you to fill in. Yeah. So with during my time as a minister, it's, one of the things that we get as a minister is bring forwards, which is a huge part of what MLAs do, is they bring concerns forward from their constituents, and so there has been a mass from that region. And so when Dan first came on, I that was my first direction to him, was to go to the DECHO, because I had been, and I am familiar with the Beaufort Delta. I've traveled into the Sawtoo. I've been to a lot of the other communities. However, I hadn't been into the DECHO, but there was a lot of issues and concerns being brought forward in regards to medical travel and, and people having a hard time accessing healthcare. So I sent Dan in there with a team to go and make sure he did a deep dive as to what the real issues were. And when they came back to me, they highlighted that there is some issues, and they would be dedicating the plan on. That's kind of where they went, just that, and they calling it the DECHO journey. So they partnered with the Department of Health, our Cultural Safety and Anti-Racism Unit, as well with the NTHSA, and they went in and they worked with the DECHO Health Authority and went and did an assessment and met with the staff in each of the communities. And what they found was that there was many times where the DECHO is serviced by Fort Simpson, and they're have a chronically short staff. And so that impacted the smallest communities, our health cabins, which they were not seeing their regular scheduled nursing times, usually once a month. And there was one community that hadn't seen a nurse in a year. So what we have in those communities, like Jean Marie, we have a community wellness worker. And when the staff went in and met with them, they wanted to know how they did their job and what are some of the things that they felt that they needed. And so with that, that's when they came up with the training plan. So now what they did was they started, and I think we're in week 13 now, I believe, of the training, of a 24-week training. So they started with the basics. They wanted to make sure that they were teaching them the equipment that are in the health cabin. They wanted to make sure that they could do a set of vital signs. So if they had to call the nurse in Simpson, they knew how to do a set of vital signs on somebody, that they could bring that information forward. They knew how to use the equipment. If somebody, they've been training on point of care testing, so they can do like the basics. So if somebody came in and they had a fever, okay, the nurse might say, well, can you do your analysis? They know how to do that now. And so if it comes back that they have an infection, they could now, and then they can give them some antibiotics. And so they also have done some work with understanding the medications in the system, and they've created a system where the nurse can observe virtually them counting, and so for immediate, give them some antibiotics before the prescription comes in. So there's these basic steps that where there was nothing in those communities. And so this training, like Mr. Florazone says, is those 4 communities where they did the first observations and kind of set it from that. But then they included Copal Lake and Kaladeche and Sigachik, because those are the other health cabin communities that have community wellness workers in. And they're also kind of training some of the home care workers as well, the home support workers, so that they can have the same training. Because some of these communities, there's only a community wellness worker and a home support worker. So if they can get trained on all of the things together, they can also cover for each other when one is off. So when there's emergency or somebody comes to the health cabin, they have the basic skills to communicate to the nurse on the other end of the telehealth or the phone in Simpson. And if there's anything more you want to add, Dan?
That was excellent. So I think that that gave you a really comprehensive sense of where things are going. So we talked a lot about education. I spoke somewhat about technology and innovation. Connectivity, again, is something we looked at on every site visit, but also the opportunity for additional equipment. And again, I mentioned point-of-care testing as well as virtual care. We looked at itinerant services. We looked, and you'll hear more about this, at nurse practitioner services into those cabin communities. And the minister has led us to and approved an expansion in nurse practitioner. We now have a shared arrangement with 2 nurse practitioners who provide services into each of those cabin communities. We looked at infrastructure. We looked at the buildings themselves, and there's quite a bit of variability. We looked at access in those buildings and setup. We also dove into operations and logistics and medical travel. What we've done is asked our Indigenous advisors, with permission, to travel with patients from those communities, right through from health cabin to health center to hospital, Stanton, in this case, and south into Alberta. What we want to do is have that lived experience and reflect that in our improvement work. So service delivery overall, we've looked at, and that has set out an operational action plan that I was referring to. So it's almost like a list of individual training, timeframes for those training, the technology, timeframes to establish that technology, and we're working that plan hard. The benefit of a deep dive like this is it's all of territorial administration support and attention to be able to learn deeply about what's actually going on. So where to next? Stay tuned. But where we're leaning is a dive into Yellowknife. So while we believe emphatically that the needs are out there, that the regions deserve a great deal more attention, we know from all reports that there are problems and opportunities here in Yellowknife. So the dive into Yellowknife that we envision is starting April 1st, giving us time to finish up DECHO, to do some really important work that we're undertaking around medical travel, but to dive into Yellowknife in a way that follows the patient, from seeking appointments and seeking access, that engages the teams in idea generation on how we can make improvements. It looks at the technology from scheduling software all the way through to how we handle phones, to staffing, to looking at our teams and asking the question, should there be nurse practitioners? Are there things we can learn from primary care that's being delivered in the regions and apply them to Yellowknife? So we have some wonderful resources and lots of learning in the regions that could be applied here. So there's lots of policy work that's been taking place and will continue. We're actioning it. So the minister has given us clear direction, and that's what we've been doing, deep dives.
Just quickly, which was the community that didn't have a nurse for a year, didn't see a nurse for a year?
Sorry?
Which was the community that didn't see a nurse for a year that you referred to?
So I believe it was Jean Marie, and when we did talk with them, so what was happening is there was no nurse traveling in, so that meant everybody who needed to see a practitioner was having to travel into Simpson. So every time, like the community wellness worker, if somebody was needing to see a practitioner, they had to send them to Simpson. And so it's not that they weren't, but not everybody wants to travel, and so that's so that's why we're trying to make sure that, and there's a cost to that, because we all know that not everybody has vehicles, so that they can't afford to drive in, so we don't, with the transportation piece, and that's where the logistics, that's where we're coming in, and we're trying to look at when we have the nurse practitioners into these communities now, when they do have to travel, logistically, do we make sure that, when we're people who do need to see the physician in Simpson, they set up a time where they all fly in together, see the physician and schedule appointments, and then go back to the community the same day, rather than sending in a plane every single time to bring one person in and back home in the same day to see a physician, because currently that's what's been happening.
Okay. On the subject of you mentioned, Minister, the annual deficit in NWT healthcare spending and the need, as you put it, to be right funded. How big is that deficit, which I recognize might be a bit of a Terence question, a sustainability question? And is it realistic to expect that healthcare deficit to be erased anytime soon, say in the next 5 years? Is that achievable, or is it about having a smaller deficit in terms of what is achievable here?
Sorry, I'll turn that over. Yes. Who wants to take that?
You're good. Or me? I'll start.
Okay.
Sure. So the deficit obviously has been a key area of since day one of my attention. Part of the deficit is attributed, in fact, probably half of it, to medical travel. If we can get medical travel right funded, in other words, what funding we receive from the federal government to compensate fully for ISC, NIHB, Indigenous patients that are traveling, that's an important negotiation that's going on right now. Our undertaking the first 3 months of the new year will be to look at logistics across the territory. We're interested not only in dealing with medical travel. Well, let me put it this way. Quality is what our drive is. We want a better system of medical travel that better meets the needs of those that are seeking care. Efficiency is a byproduct of quality. When we looked in the debt show at the health cabins, we went through 600 records of travel. It was estimated that 30%, as a target, 30% of that travel could be avoided. That wasn't done in an effort to save money. That was done in an effort to say 30% is actually our target for providing care at home or as close to home as possible. It just turns out that if we can figure out the right strategies to provide care in place, we avoid the trip that creates the burden on the next facility that people are going to. It's not lost on us that there actually may be more travel that results from better care. Sometimes we'll be able to pick up on needs that maybe weren't seen as soon. So the nurse practitioner that's deployed to a health cabin community may pick up on someone that needs to see a specialist, needs to see a practitioner or another health team. This is a good thing. So we'll see a bump in appropriateness. We'll also see a reduction in health travel because of appropriateness as well, and care being provided closer to home. So what's important also in unpacking in health travel and medical travel is communication, the use of escorts, the timelines, the logistics. The minister mentioned planes flying, empty or full. Could we coordinate clinics on the same day and coordinate on scheduled flights, patients having their appointments? It's a case management feature that really hasn't been part of our medical travel policies or delivery. So we had some real opportunities here to do some things. Again, I'll be back like a broken record. We're going to do a deep dive on medical travel. This time from logistics, communication, escorts, and timeliness of getting your approval, so it's not just last minute.
Yeah, thanks, Dan. I think there's certainly recognition that the deficit that has accumulated over the last number of years has caused us to take a look at the sustainability side of it, and that's really going to be the focus of our unit. Dan already mentioned, or Mr. Flarzone already mentioned, some of the bigger cost drivers. Medical travel is one of them. But some of the work that we did in our preliminary review has identified other areas as well that's driving some of the costs, and that's going to be the area of focus of our work initially as we get into the second phase of our work. Right now, we're working on supportive living and bed-based addictions as those two priorities. But when we say right size the budget, it's not just about asking for more money or adding more money to that conversation. It's really about looking for those opportunities to improve efficiencies and improve financial sustainability. And I'm mindful of the 4 objectives that Minister Semmler mentioned in her opening remarks, where we always got to have access back to, or a direct line of connection back to, cultural safety and improving access to healthcare for our residents.
Just to quickly restate the question. I just wanted to quickly restate the question, which was like, is there intention to eliminate that deficit, let's say by the end of the decade? Is that the intention?
Do you want me to start? Then you can fill that in.
Please go. Yes, Minister, please.
I think where we are, and I think if we look at it, Terrence might have the actual data. The deficit is over 300 million. And right now where we're sitting, and I think every year, and I believe last year, the deficit was just under 70 million. And this is why we're looking at it. We're looking at where we can access more funding. And so we have been accessing more funding, pushing for funding from, for instance, NIHB. We've gotten that special allotment that we never ever had before, where for the past 2 years, we were able to secure 24 million a year to add to the deficit of the medical travel that we've been spending. And so what we're trying to do is we're trying to ensure that the program that we have, the core programs and the programs, and that's what Terrence is doing, is that the core programs that we have and making sure that we're adequately funding those, so that we're bringing forward changes to our system with these improvements. So when we move forward, that we have a balanced budget going forward. The deficit, this is where as the minister, I'm sitting here going, this is a conversation that I would have to have with my financial management board colleagues with how we're going to move forward with that in the future. Right now, we're just trying to work on making sure that we have the adequate amount of funding, and we're making sure that through the work that the health sustainability unit is doing, is that we're putting in improvements and efficiencies into the system. So we're not spending money in places that is not really a good area to put our investments in. I'm not saying that, and I think that's our issue where with medical travel, when we're not logistically watching how we're moving people in the community that's costing us extra millions of dollars to our deficit. That's where we need to find those sustainabilities to streamline and do those logistical pieces. I'll turn it over to Terrence if there's anything you could add.
Thanks, Minister. Just very quickly, so that annual deficit, it ranges depending on the year, but it ranges somewhere in the neighborhood between $25 million per year all the way up to the number that the Minister just quoted in the high 60s. And it's really that number that we're trying to eliminate in terms of achieving sustainability going forward. So we have a couple different, we got a lot of initiatives going on that address sustainability. But what we are trying to do is get some meaningful recommendations forward to Minister Semmler and the Premier in advance of the 27-28 business planning cycle that will address hopefully most of those annual deficits that we experience. And then it'll be a process. The process is intuitive, and it's going to be a process of continuous improvement. But yes, the intent is to eliminate that annual deficit going forward.
Lisa?
Just had one more question.
Okay.
If there's time. Thank you. So the other question I wanted to ask, I'm just wondering if the choice to go to Yellowknife next, is that related at all to, I know that there's a lot of applied and also explored communications technologies happening in cities like Yellowknife and Inuvik that are related to, to the military, the bases and things. Is there any connection with the choice with the communications technologies?
I think the reason we're going into Yellowknife is the priority where I went was the Decho because I heard so many concerns coming from there. But the next area of concern where I hear so many concern is the capital. So when we amalgamated all of our 4 teams into the Klubabunti building for the primary care, we continue to have the downtown primary care walk-in clinic. And there are scheduled appointments there. However, and I think every Yellowknife MLA has raised different concerns, and I've had different concerns raised to me from residents of Yellowknife that email me directly with their frustrations on trying to get an appointment. And so as we had the briefing yesterday, and I think one of the biggest pieces is this struggle, and we have MLAs saying, well, we want to have the same kind of team-based care as in this models of small communities, whereas you have nurses, you have nurse practitioners, and you have different, but that's what the team-based care is in Yellowknife. However, we still have this struggle of, people, the clinics in Yellowknife, before they used to be private clinics owned by physicians, and they were physician-based care. Then a few years ago, all the physicians now are contract workers of the health and social services, like NTHSSA, and so they don't run their own clinics. However, they work in our system, and they work within our primary care clinics. And so what we're trying to do is we're changing, and it's been across right across Canada. Everybody's going through this primary care reform, whereas it's based on team-based care. And it's to support the physicians because, there's things that the LPNs and the team can do when people need to see somebody in their team, whether it's the community health nurse, whether it's the nurse practitioner. And then if it's more complex beyond the nurse practitioner, then they would be referred to the physician on that team. However, across Canada, there's still this change that we have to kind of have for everybody is that when you're calling into the clinic and you're booking an appointment to see a health practitioner, it may not be the physician. It's going to be the most appropriate healthcare provider for what you're needing. And so it's that change that people phone in and they want to see their doctor. And the doctors are busy, and I think the thing is that we want to free them up to make sure that they're seeing the patients with the chronic diseases and that are more complex, because they're also our hospitalists, they're also our emergency doctors, they're also our obstetric doctors, so we need to make sure that that they have the time to be able to do their clinics as well as all their other pieces. So with all that change happening at once, moving in and then moving into a new place, it's caused a lot of chaos in how people access care in Yellowknife. And so that's the why I think when we made the decision and I had the conversation with the public administrator that we need to go here next. Because this is half the population, and if they're having problems accessing the first level of primary care, you know, and then they're ending up having to sit in the emergency department for something that should be seen in a clinic, then we have some issues here and we need to resolve those. And so by doing that deep dive into Yellowknife, we can highlight what those issues are so that we can do those recommendations and make some internal quick changes if like whatever the low hanging fruit is, and if there's things that we need to go back to through our processes to access, you know, whenever we have to spend more money, we have to go through our internal processes to be able to do that.
Thank you.
Ollie, in the end.
Uh,
The last.
Just one last question. I want to talk about staff safety a little bit. In the course of reporting on the events in Fort Resolution over the last few years, we heard from a significant number of community health nurses in the NWT about staff safety as an issue. I note that the latest of the 52 improvements in 52 weeks initiatives is about staff safety at the health cabin in Colville Lake. I'd be interested in hearing possibly from Dan, also from the minister, on if you have a message for staff, for nurses in communities in the NWT about staff safety, how that's being approached. And maybe you could tell me a little more about Colville Lake as an example. I'd be interested in hearing more about what your message is to staff about how the health authority, the department, are ensuring that staff safety is a priority.
I can turn that over to you, Dad, because I know you have that on your work plan.
Yeah, really a great question, and thank you for it. Right now, just to kind of set the context, the least safe industry in Canada, as far as workers' injury, is healthcare. We're less safe writ large than construction, than mining, than transportation, than any other area. Probably the number one is soft tissue, musculoskeletal injuries that occur, lifting, transferring, heavy care, heavier patients, putting yourself in that position. The emerging one, particularly through COVID, pre-COVID, through COVID, post-COVID, has been violence. And the staff have across Canada have raised these issues. We have undertaken some very significant learning and work at Stanton. These include physical barriers. They include codes. They include the way we communicate, the way we train, with the way we assess patients and risk. You're going to see in the coming period, I'm wrapping up my year one work plan. Year two work plan is going to be around a risk management strategy that places this feature at top of mind. We're doing a dive and will be in the new year around what's injuring our workers, what are some of the strategies that have been promising practices. We've asked staff, the message to staff is, what can we do? What are some of the small steps that we can take while the longer term work is being undertaken? So if there's a theme in all of this work, it's that we're not waiting for some magic to occur in 3 to 5 years. You know, a new system, new software, new equipment, new lifts, new transfer and positioning. What we want to do is we want to come up with an engaged workforce with ideas and innovations that can happen now, while we're working on those longer term issues. So on the violence front, again, there's a more fulsome presentation that we could provide through Stanton. It's from my view, from what I've seen, it's not only a promising practice, but it's a practice that should be shared across Canada. I can't speak specifically to Colville Lake and the idea generation that occurred there, but we're trying to encourage every single health cabin, health center, hospital within the territory, home care, public health, every service provision to think about safety first, to do their assessments, to place it first and foremost, from winter travel and having vehicle maintenance issues on the road, all the way through to our client interactions. It's top of mind. I'll have a more fulsome plan and a more fulsome briefing for you at a later date. I just don't have the data in front of me and the fulsome plan, but it's part and parcel of the priority. Saying keep yourself safe is insufficient. We need to think about partners. We need to think about security. We need to think about the service of alerting someone to your location, alerting and getting phone backs or callbacks, or when you're traveling. We need to be able to have response, and those are emergency buttons and codes that are being used throughout to be able to have a response where possible in the immediate term to prevent a mishap, an accident, an issue.
Thank you, everybody, for coming in today. And thank you, Minister, for joining us despite the flu. Thank you, Terence. Thank you, Dan. Thank you, Alan, for joining us. And thank you, Lisa and Ollie, for asking all the questions. This concludes this briefing. Thank you.